Vanakkam. We have learnt about what are all the problems that can occur at the elbow, at the forearm, at the wrist and hand and fingers following birth brachial plexus palsy in the previous video. So it is now natural to try to understand what is the management of each of these problems. So we need to learn the different options of management available. But that is not enough, because we also need to learn in which situation we use which option, that is the decision making. And what better way to understand decision making than by the use of algorithms. We shall use algorithms for the management of each of the problems, each of the sequelae affecting the elbow, forearm, wrist and hand following birth brachial plexus palsy in this video. When we need to talk about the management of elbow and hand problems in birth brachial plexus palsy or B2P2, we need to look specifically at problems at the elbow, problems at the forearm and problems at the hand and wrist. And when we talk about problems at the elbow, we are talking about three main problems: elbow flexion contracture, weakness of extension and weakness of flexion at the elbow. And when we talk about problems at the forearm, we are talking about two problems: supination deformity and pronation deformity. And considering problems at the hand and wrist, there are many problems, the three most important of which are ulnar deviation, weakness of extension of the wrist and weakness of the fingers at the metacarpophalangeal joints and instability of the thumb. But before we even talk about the management of these problems, we need to remember some basic points. The child must be cooperative, at least to a certain extent. The parents should understand the objectives of the surgery and should be willing to work hard with their children to obtain the best result possible. We also need to remember and follow the basic principles of tendon transfer and pre-operative therapy program to strengthen the donor muscles will emphasize to the parents of the children the importance of therapy. Studies have shown that the optimal age for surgical correction of these problems would be the preschool years for shoulder and elbow reconstruction and the school going years of 6 to 13 years for forearm and hand reconstruction procedures. Let us first consider the management of secondary problems of the elbow, the most important of which is the flexion contracture. The details of this problem can be seen in the video that I have uploaded earlier. There are basically two modes of management of the flexion contracture of the elbow in birth brachial plexus palsy: serial casting or stretching and surgical management. The aim of serial casting is to improve the attitude of the limb at the cubital level. The POP cast is applied with the elbow in maximum stretch possible. This is changed every 2 to 3 weeks and every time the elbow is stretched just a little further. Usually about 3 changes are required before the elbow comes into full extension. Then a static elbow extension splint must be applied and simultaneously anti-gravity tricep strengthening exercises are started. As far as the surgical correction is concerned, in mild flexion contractures of about 20 degrees to 50 degrees, no surgical treatment is required. If it is a severe flexion contracture that is more than 60 degrees, surgical treatment is absolutely indicated. But we need to remember that correcting the contracture will weaken the biceps. The surgical options available are Z-plasty of the skin, Z-plasty of the biceps and other procedures, and procedures for reduction of the dislocated radial head. The commonest procedure done to release the elbow contracture is lengthening of the biceps tendon. The incision is made as follows. It begins on the lower arm on the lateral aspect, extends along the elbow crease and then along the medial aspect of the proximal 1/3 of the forearm. The biceps tendon and the lacertus fibrosus or the bicipital aponeurosis are exposed. First, the lacertus fibrosus is divided close to the tendon. Then a Z lengthening of the biceps tendon is made as shown in the diagram. It is then sutured again after extending the elbow to maximal position. There are many such procedures for the management of elbow flexion contracture in birth brachial plexus palsy. Let us see an algorithm for deciding on which procedure is to be done. The elbow flexion contracture is first examined to see if it is less than 60 degrees or more than 60 degrees. If it is less than 60 degrees, conservative management in the form of serial casting is done. If it is more than 60 degrees, we need to assess on X-ray the elbow joint congruency. The elbow joint may be congruent or not congruent. If the elbow joint is congruent, soft tissue release procedures like Z-plasty of the skin, release of lacertus fibrosis, Z lengthening of the biceps, partial release of the brachialis and brachioradialis, anterior capsule release or fractional lengthening of the pronator mass can be done. If the elbow joint is not congruent, we need to assess whether it is only the radial head that is dislocated or both the radial head and the ulna are dislocated. If both the radial head and proximal ulna are dislocated, no surgery is indicated. If only the radial head is indicated, we need to see whether passive reduction is possible or not possible. If passive reduction of the radial head is possible, surgical options like open reduction of the radial head, annular ligament reconstruction, or pinning the radial head to the capitellum for 4 to 6 weeks can be done. If passive reduction is not possible, we need to evaluate on MRI the joint space. If the joint space is preserved on MRI, the same surgical options are available. If the joint space is not preserved on MRI, surgery is not indicated. When there is weakness of flexion of the elbow, many options are available like stainless flexor plasty, pedicled bipolar latissimus dorsi muscle transfer, pedicled pectoralis major muscle transfer, anterior deltoid to biceps transfer, or even free functional gracilis muscle transfer. We shall now see the basic concepts of the commonly done procedures. The basic principle of the stainless flexor-plasty is that the common flexor origin that arises from the medial epicondyle is dissected out, and along with the bone that is the medial epicondyle, it is shifted proximally and fixed to another point on the anterior surface of the lower end of humerus. By this procedure, the common flexors of the fingers and the wrist become flexors of the elbow. While doing this procedure, it is important to note that the ulnar nerve enters between the two heads of the flexor carpi ulnaris, and it is important to preserve this nerve during this procedure. Bipolar pedicled latissimus dorsi muscle transfer is also a commonly done procedure to get back elbow flexion. The incision is made as shown. The latissimus dorsi muscle is dissected out completely, preserving the neurovascular bundle, and the origin and insertion are divided. The entire muscle based on the intact neurovascular bundle is tunneled to the arm, where a new origin, usually the coracoid process, and a new insertion, that is the biceps insertion, are given. The pectoralis major muscle transfer can also be done in the same way. This diagram shows the incision that is made. The dissection of the pectoralis major is done along with the intact neurovascular bundle and the extra portion of the fascia over the rectus to provide the increased length. It is tunneled to the arm, and new origin and insert are given as already explained for the latissimus dorsi muscle. The triceps can also be transferred to the biceps to provide elbow flexion in certain conditions. The insertion of the triceps is dissected out, taking care to prevent injury to the ulnar nerve. The insertion is divided, and the periosteum over the olecranon is also included to provide increased length, which is then tunneled to the flexor aspect to be sutured to the biceps tendon. Now let us see the algorithm for management of weak elbow flexion in birth brachial plexus palsy children. When there is weak elbow flexion, we need to check whether it is MRC grade 0 or 1 or MRC grade 2 or 3. If there is almost no elbow flexion, we need to check the strength of the wrist extension and finger flexion. If it is good, we can do stainless flexarplasty. If it is poor, we need to do other muscle transfers like pedicled bipolar latissimus dorsi muscle transfer, pectoralis muscle transfer, or even free functioning muscle transfer. If elbow flexion has an MRC grade of 2 or 3, we need to check for co-contractions. If there are found to be co-contractions, we need to check whether they are triceps co-contraction or deltoid co-contraction. If it is triceps co-contraction, we need to try Botox into the triceps to look for increased elbow flexion, in which case it is successful and nothing further needs to be done. If Botox injections are unsuccessful, we need to do a triceps to biceps transfer. If there are deltoid co-contractions, Botox injections must be tried as was done for triceps co-contraction. If unsuccessful, anterior deltoid to biceps muscle transfer can be done. If there are no co-contractions, the procedures can be done as discussed for grade 0 or 1 of elbow flexion. If there is weakness of elbow extension, procedures like biceps to triceps transfer, brachialis or brachioradialis to triceps transfer, posterior deltoid to triceps transfer, bipolar latissimus dorsi transfer, or free functioning gracilis muscle transfer can be done to provide extension of the elbow. Let us see an algorithm to decide on which procedure to be done in which condition. If the weakness of elbow extension is associated with an elbow flexion contracture of more than 60 degrees, we need to release the contracture and then do a brachialis to triceps transfer. If there is no elbow flexion contracture, we need to check the strength of the brachioradialis. If it is good, we can do a biceps to triceps transfer or even a pedicled brachioradialis transposition transfer. If the strength of the brachioradialis is poor, we can do a posterior deltoid to triceps transfer or a pedicled bipolar latissimus dorsi transfer, trapezius transfer, or a free functioning muscle transfer. Now we come to the secondary problems of the forearm, of which the most important is the supination deformity. Prevention of the supination deformity is very important. In patients undergoing shoulder rebalancing surgery with weak forearm pronation, shoulder spica should be applied with the forearm in mid-prone position. Early identification and surgical treatment prevents bony changes and improves digital flexion also. Just a supination deformity can become a contracture by 2 years of age, and when it becomes a contracture, passive stretching and manipulation cannot treat it. When considering surgical management of a supination deformity of the forearm in birth brachial plexus palsy, we need to consider certain factors. The type of the deformity, whether it is flexible or fixed. We also need to assess the strength of the triceps muscle, congruency of the radioulnar joints, and also look for coexisting shoulder deformities which should be corrected first. We also need to consider the wrist function. The active wrist extension power of grade 3 or more is a must for surgical management of supination deformity. A mild to moderate elbow flexion deformity can be accepted and the supination deformity can be corrected, and sensation on the hand is very important. In an insensate hand, if we provide pronation, the child will not have a visual input and hence trophic ulceration may develop. The surgical options available for management of the supination deformity depend on whether it is a fixed deformity or a flexible deformity. If it is a fixed deformity, the procedures indicated are interosseous membrane release or a forearm osteotomy, and in a flexible deformity, the procedures indicated are tendon transfers like biceps rerouting, brachioradialis rerouting, or biceps lengthening. One of the important causes for a fixed supination deformity developing is the interosseous membrane tightness. For a partially fixed deformity, release of the interosseous membrane through a dorsal approach followed by biceps rerouting can be done. If the stiffness of the supination deformity is very severe, an osteotomy of the forearm bone or bones needs to be done to correct the deformity and get back passive pronation. An isolated radius osteotomy is adequate for moderate supination deformity, but both the radius and ulnar osteotomies need to be done for severe deformities. The forearm needs to be stabilized in 30 degrees of pronation after the procedure, and this must be higher in younger children as remodeling occurs over time. After an isolated radial osteotomy, deformity recurs in 20% of patients. But when this osteotomy is combined with biceps rerouting, there is almost no recurrence. The procedure is done by making an incision on the volar and radial aspect of the forearm. At the junction between the proximal and the middle thirds of the radius, the osteotomy is done. The forearm is then pronated to the maximal limit. In the fully pronated position, fixation is done either with K-wires or semitubular plates. And following skin closure, a long arm cast is applied. It is important to apply this cast with the elbow flexed in 90 degrees, forearm positioned in maximal pronation and wrist extended to 30 degrees. This cast needs to be maintained for 6 weeks and it is converted to a thermoplastic splint after 6 weeks. Rotating the radius alone gave only moderate correction of about 58 degrees. An osteotomy of the ulna alone gave only 15 degrees of correction, whereas a stepwise rotational osteotomy of the ulna and the radius gave more corrective pronation, almost 101 degrees in a particular study. When the supination deformity is flexible, the procedures of biceps rerouting or brachioradialis rerouting can be done to get back active pronation. Biceps rerouting is indicated in flexible supination deformity with active triceps function. The bicep strength should be grade 4 or more to provide active pronation without jeopardizing elbow flexion. The biceps tendon is identified and dissected. The tendon is divided in a Z fashion. The slip attached to the radial tuberosity, that is, the distal slip, is rerouted around the radius from anterior to posterior to bring out on the radial aspect of the radius and sutured to the proximal Z limb while keeping the forearm in full pronation and elbow in 90 degree of flexion. This route converts the biceps from a supinator to a pronator. A cast is applied in the position described earlier. For brachioradialis rerouting, the tendon is divided in a Z manner over a length of 6 to 8 centimeters to get two long slips, one distal and one proximal. The distal slip attached to the original insertion site is rerouted around the ulnar side of the radius through the interosseous membrane to the dorsum and sutured to its proximal Z limb while keeping the forearm in full pronation. With this rerouting, the brachioradialis now has a pronation torque and can cause active pronation on contraction. Now let us see an algorithm for the management of the supination deformity in birth brachial plexus palsy. A supination deformity could be passively correctable, it could be correctable but stiff, or a fixed deformity. If it is passively correctable and the triceps is strong, biceps rerouting is advisable. But if the triceps is weak, a brachioradialis rerouting is advised. If the deformity is correctable but a little stiff, interosseous membrane release needs to be done combined with biceps or brachioradialis rerouting depending on the strength of the triceps. But if the deformity is fixed, we need to see whether the radial head is dislocated. If it is not dislocated, we can do a forearm pronation osteotomy. If the radial head is dislocated, an osteotomy combined with biceps rerouting should be done. The other deformity that can occur in the forearm is the pronation deformity. This again could be a fixed deformity or a flexible deformity. If it is a fixed deformity, an interosseous membrane release or a forearm derotation osteotomy needs to be done depending on the degree of the stiffness. When the deformity is flexible, that is, passive pronation is very easily possible, tendon transfers can be done. But before this, evaluation of the donors is very essential. The commonly done tendon transfers to get back active supination are the flexor carpi ulnaris to the brachioradialis transfer and the pronator teres or brachioradialis rerouting. First, the flexor carpi ulnaris tendon is identified and the muscle is mobilized till the proximal forearm. The brachioradialis tendon is also dissected and identified and divided into two slips. The flexor carpi ulnaris tendon is now rerouted around the ulnar border to the dorsal aspect and sutured to one of the slips of the brachioradialis to make up for the length. This suturing of the tendons is done with the forearm in complete supination. For pronator teres rerouting, the pronator teres is elevated from its insertion with a periosteal extension and rerouted dorsally along the ulnar border of the radius to reach on the radial aspect of the lower end of the radius. It is inserted over the anterior aspect of the radius at the level of its original insertion site. The pronator teres now works as a supinator instead of a pronator. The procedure of brachioradialis rerouting to achieve active supination is similar to the procedure described earlier, but there is a difference. The brachioradialis tendon is divided in a Z manner over a length of 6 to 8 centimeters to get two long slips. The distal slip attached to the original insertion site is rerouted radial to the radius and then around it and brought through the interosseous membrane volarly and sutured to its proximal Z limb while keeping the forearm in full supination. By this route now the brachioradialis provides a supination torque. This is different from the procedure described earlier for achieving full pronation. Now let us see the algorithm for management of pronation deformity in birth brachial plexus palsy children. The pronation deformity could be passively correctable, it could be correctable but stiff, or it may be a fixed deformity. If it is passively correctable, a tendon transfer procedure like flexor carpi ulnaris to the brachioradialis or pronator teres rerouting, brachioradialis rerouting, or even a flexor carpi ulnaris to extensor carpi radialis or brevis can be done. If the pronation deformity is correctable but a little stiff, interosseous membrane release followed by tendon transfer is ideal. If it is a fixed deformity, radius supination osteotomy should be done. There are many secondary problems associated with the wrist and hand in birth brachial plexus palsy children. The commonest are ulnar deviation deformity at the wrist, weakness of wrist extension, weakness of extension of the fingers at the metacarpophalangeal joints and thumb instability, weakness of flexion of the digits and loss of sensation. The ulnar deviation deformity at the wrist is the commonest problem. It is functionally hindering and socially awkward as we have already seen in the previous video. It is commonly seen in Narakas groups 2, 3 and 4. It occurs because the C7, C8 innervated muscles, the abductor pollicis longus, extensor carpi radialis longus and brevis and the flexor carpi radialis are weak or paralyzed, while the C8 T1 innervated muscles, the flexor carpi ulnaris and the extensor carpi ulnaris may get re-innervated and have an unopposed action. In managing this problem, we need to first differentiate between whether it is the extensor carpi ulnaris or the flexor carpi ulnaris is the cause, and then use the appropriate tendon to be transferred to the extensor carpi radialis longus. The procedure is quite straightforward. If it is the extensor carpi ulnaris that is the cause, the ECU to ECRL transfer is done. The ECU and the extensor carpi radialis longus tendons are identified. The ECU tendon is divided distally and mobilized proximally in order to reach the extensor carpi radialis longus in a straight line. It is tunneled subcutaneously and sutured to the extensor carpi radialis longus, while holding the forearm in 20 to 30 degrees of radial deviation. If there is an associated flexible supination deformity along with the ulnar deviation deformity, correction should be combined with supination deformity correction also. Oskan et al. Have prescribed what is known as a switch transfer, the extensor carpi ulnaris to the brachioradialis and brachioradialis to the abductor pollicis longus. But if there is an associated fixed supination deformity, the ulnar deviation correction can be done along with the forearm pronation osteotomy procedure. Weakness of extension of the wrist is a problem seen in children with extended upper or global brachial plexus involvement. The inability to extend the wrist impairs the ability to grasp, and surgery is advised after the age of 4 years. Till then, therapy is the mainstay of management. The options available for transfer to provide active wrist extension are the pronator teres, brachioradialis, flexor carpi ulnaris or radialis, and the flexor digitorum superficialis. We need to remember that most of them may be weak because they have been re-innervated. Generally, if it is a case of extended Erb's palsy in which there is a weakness of extension, the pronator teres or the flexor carpi ulnaris can be transferred to the extensor carpi radialis brevis. But if it is a total palsy, the flexor carpi ulnaris only can be used as a transfer to the extensor carpi radialis brevis. When no strong motor donors are available, the wrist can be stabilized with a tenodesis. In adults or even in adolescents, arthrodesis of the wrist can be done. In children, a technique of chondrodesis using a double frame suture of Vicryl has also been described. Finger metacarpophalangeal joint extension is lost, and since it involves a thumb also, thumb instability is also present in some children affected by birth brachial plexus palsy. Let us see an algorithm for managing this problem. When there is no extension at the metacarpophalangeal joints of the fingers, we need to check whether wrist ulnar deviation is present or absent. If wrist ulnar deviation is present, we must ascertain the cause of the deviation, whether it is the flexor carpi ulnaris or the extensor carpi ulnaris. If flexor carpi ulnaris is the cause, we can do a flexor carpi ulnaris to extensor carpi radialis longus transfer to provide wrist extension. Flexor digitorum superficialis of the little finger can be transferred to the extensor pollicis longus and the extensor digitorum communis of the index finger to provide extension at the index and thumb, and flexor digitorum superficialis of the ring finger can be split and transferred to the extensor digitorum communis of the middle, ring and little fingers to provide extension of the metacarpophalangeal joints of those fingers. If extensor carpi ulnaris is the cause of the wrist ulnar deviation, the protocol is the same as already described, except that the extensor carpi ulnaris will be used as a transfer to the extensor carpi radialis longus to get back wrist extension. If wrist ulnar deviation is absent, we need to look for whether wrist extension is present. If it is present, we will have to reconstruct only the extensors of the fingers and the thumb, which can be done using the flexor carpi radialis and the palmaris longus, or alternatively, we can use the flexor digitorum superficialis of the ring and little fingers or the middle and ring fingers as described previously. If wrist extension is absent, we also need to reconstruct wrist extension. This can be done using the pronator teres, which is transferred to the extensor carpi radialis brevis, or the flexor carpi radialis, which can be transferred to the extensor carpi radialis brevis. The extensors of the fingers and thumb can be done as already discussed. In case of weakness of flexion of the fingers, the active biceps can be used to power the finger flexion. If beyond the age of growth of the joints, arthrodesis of the interphalangeal joints can be done. Sensory loss is also a feature of the hands of children affected by birth brachial plexus palsy. Though Al-Katan had reported a 4% incidence of accidental contact burns in neonatal brachial plexus palsy, sensory function is usually markedly less severely affected than motor function, and most of the children become accustomed to the paralyzed hand or the insensate hand. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see the entire playlist about birth brachial plexus palsy, the features and management in this link that has been shown. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.